These first couple of slides, I know you can all read, but I want to read it verbatim because it's exactly the definition that comes out of the CPT book. It's defined, critical care is defined as the physician or physicians' direct delivery of medical care for critically ill or critically injured patient, or a critically injured patient. A critical illness or injury acutely impairs one or more vital organ systems, such as that there is a high probability of imminent life or threatening deterioration of a patient's condition. But it involves a high complexity decision making to assess, manipulate, and support vital system functions to treat single or multiple vital organ system failure and or to prevent further threatening deterioration of that patient's condition. And examples of those that we look at are, and I'm not clinical, the central nervous system, circulatory failure, shock, renal, hepatic, metabolic, and or respiratory failure. It could also be other life-threatening situations. It doesn't necessarily have to be exactly those systems that are listed there. And to do critical care reporting, the coders are actually reading through the medical record and picking up critical care based on time. It's a time-based code. So for example, if it's less than 30 minutes, you've done some work on this patient and you pronounce them, we actually revert back to the appropriate E&M code, the 99281 through 99285, which we spoke about last time. And we base it on the key components, the history of the present illness, the exam, and then your medical decision making. But if it gets into 30 minutes or more, we take it the first 74 minutes, the first 90 minutes. It's broken out, we round up past a certain point, is 99291, and then each additional 30 minutes gets another code for each 30 minutes that we meet, and that's the 99292. We're going to take care of the total time and reporting of those CPT codes, but for your value, the work RVU for those, the 99291 is 4.5, 99292 is 2.25, and I threw in a couple of codes that would probably be associated with critical care, maybe not always. CPR, if you're performing it or running the code, you get 4.0 for work values, and then endotracheal tube insertion is 2.33 in RVU values. That's probably more meaningful for you than the 99291, 99292.
So that first one up here is 99291 is simply, is that 4.5 per half hour?
It's 4.5 each time the code is listed, so that's going to be your first 30 minutes. And then 99292, that 2.25 will be each additional 30 minutes that we multiply that code out. So the front loaded is 4.5 and then each additional. Time is very important because it's a time-based code. The progress note must contain the documentation of the total time for critical care. Without it, we can't code or support the 99291 reporting. So in the teaching setting, it's the actual time spent by yourself, not the resident, and not the student, I should say. It's the resident, it's your time. It has to specifically be your time, and it's not the time you spent teaching the residents. That doesn't count. Again, if it's less than 30 minutes, we're going to take the E&M code. And there's a caveat, though, for a level 5, if it's less than 30 minutes. CPT says if you can't obtain a comprehensive history or exam because the patient's unresponsive, unconscious, etc., you just need to state that in your note, and that's going to give you full credit. The emergency room is the only place they allow that caveat. We can't do that in the physician office or clinics, etc. It's just the emergency room. But if you just write unobtainable, you're not going to get full credit. You have to state why. That's very important.
Is that only for critical care, or is that for all patients?
That's for all patients. You can get a full, that's their little caveat, full credit for a comprehensive history, comprehensive exam, if it's unobtainable, but you tell me why. For the time spent for a critically ill patient, it has to be the total time spent and devoted to that specific patient. You cannot be caring for another patient at the same time you're reporting critical care for that critically injured patient. It doesn't have to be continuous time. It can be interrupted, and you can total like 30 minutes here, 30 minutes an hour later. That time can be added together, so it doesn't have to be continuous. But you can't be at someone else's bedside. You can be somewhere else on the floor of the unit making phone calls, documenting in the medical record. physicians, but it has to be on that floor or unit, and it has to be devoted to that critically ill patient. So if you go to your office and make a phone call, that's not reportable. It has to be on that floor.
So, sorry, so you're saying that the time that I spend on the phone speaking about the patient with our consultants regarding that patient
As long as you do it in the unit, it's counted.
is in the ED?
If you leave the ED and go back to your office and make phone calls, they don't count it per se.
What about if you accompany the patient off your unit to?
If you're still with it, if you're still with the
Yes.
patient, that's counted as critical care. Discussions with family members or surrogate decision makers can be counted as critical care as long as it's devoted to the conversation, or the conversation bears directly on the management of that patient. I know sometimes discussions are lengthy with families because of the nature of the critically injured patient, but if it doesn't directly relate to the management of that patient, that also cannot be counted.
Can you just give it,
And I knew you were going to ask me that, and I'm not sure.
from the example standpoint, okay, can we just dictate or type that we had long discussion with the family regarding treatment of the, intracranial hemorrhage, and also talk to the family regarding the DNR status? Is that all we need to do?
I'm going to take that, if you're telling me it's part of your critical care, I'm going to take that. I don't need to know or document what you want others to know from that discussion in the note.
Right.
To protect yourself later if something gets pulled. But I'm going to count that as critical care time.
What about the whole bereavement process of, you just did a code, patient didn't make it, and you're speaking to the family for 15, 20 minutes afterwards?
This is where it gets kind of dicey. To me, I don't think it's over here.
I don't, I think it's management of the patient, I would say it's probably
Not
not
included. If the patient's already deceased and you're doing bereavement. In addition to critical care, there's time spent billing separate billable procedures. I'm going to have a list of those in a couple of slides. There's a list of codes that say are included in critical care, and then other services are separately billable. So CPR is separately billable outside of critical care, but there are some things that are not. Again, critical care involves a high complexity medical decision making. And the fact that the patient, this really doesn't pertain to you. If the patient's in the ICU, every time you round on that patient doesn't make it a critically care visit. They could be stable. If they're on a vent and they're stable, that also does not warrant critical care services. And again, the service must be medically necessary and meet the definition of critical care, which I'm sure all of our notes cover that. We wouldn't do it otherwise. I actually have to speak with you and Dr. Molinari. I want to make sure, I noticed in our critical care notes, it actually gives us a total range of time, like 30 to 74 minutes spent providing critical care. If I have to carve out separately the CPR, the time you're spent running that code, that is separately billable, I need to take it from the critical care time and then working with you to figure out how to get, I don't know if it's 34 minutes or if it's 73 minutes, and if I'm going to subtract time from that, I need it to be specific, and I don't think the EMR allows for that. So I want to work on that with you.
So in the meantime, is it better if we can note a specific amount of time? like
If you're
60
able to
minutes,
document
40
in a good
minutes?
faith estimate 43 minutes spent providing critical care, to me that's better than 30 to 74 minutes providing critical care, because if I have to carve that out, I don't know where in that range you are in critical care. So,
I guess I'm confused, are you saying that if we spend 35 minutes with a code, and during that entire time we're running the CPR until we decide the patient's not going to make it, we stop CPR, and that's the time of our critical care. Is that total critical care time, or is it separately billed from the CPR?
that's what I need to figure out, because everything I was reading over the weekend says that if it's a separately billable procedure, for example, critical care and CPR, I can bill for CPR, I can't do both. So that's something I have a lot of homework to do on, but right now, we're counting both. because the EMR only shows a range, and then you're running a code. I'm picking up both, but I need to work with Dr. Molinari and Dr. Riccio to make it hard. Because the time you're giving me, I don't know if that is the total critical care time and you excluded CPR codes, or if it's a good faith estimate. I don't know for sure. I have homework to do. But what I'm reading, anything that's separately billable, we have to carve out of critical care time.
I think from our perspective, we are billing all of that into one. I don't think we're putting in actual numerical value, and most of us are checking that box.
Box.
Yeah, but I am including it in there.
And as I understand it, even if you carved it out, we could bill CPR plus you would get, say, a level 5 visit.
Yes,
for that.
yes.
So it would be just the CPR, but you would get that in addition to your level 5, or, potentially just the critical care time, whichever would be.
And that's what I need to figure out in the EMR, if that's all included in that, or if we're separately carving it out by the time you click that box. I still need to understand that piece. But within that CPR code, they're stating that these are included in that professional component. We can't carve it out. So the chest x-ray, a blood draw, blood gases, gastric intubation, pulse oximetry, vent management, all those things that are listed there are included in the critical care reporting. We can't carve those out separate for the professional component.
And the vascular access, that's even for central lines, is not separately billable.
Correct. So from the coding process, the coders are actually combing through each documentation, the documentation that's in the medical record for every patient. And with that, we're going to assign the critical care codes and the times, the total time, either the one code in each additional 30 minutes. If we feel the chart is critical care or supports critical care, you're probably going to get a query back to you stating, please include a time. Did you feel it was critical care? And if yes, please include a time. So we can code for that. It's going to be on a white, right now, currently, it's on a white form that's stapled to some paperwork with a checkbox for you to go back and actually document in Cerner and not on a piece of paper. We're actually looking to get that into Cerner itself, so you can just see it in your inbox and not have to worry about paper charts coming back. We're working through that process right now.
So if this comes to us later, and 2 weeks after the fact, we're gonna say, look, you think this patient's critical care, but then you can't recall whether you spent, 10 minutes with another patient in room 8 and came back to room 7, and, I would assume it's gonna be better to undercode,
Yes, if it
estimate that
gets,
critical care time.
we're trying to stay within 7 days of the coding, since the data service. We're trying to stay within 7 days of coding that chart. If it's something that you're not comfortable recalling, for example, I know you've seen several patients in between. If you're not comfortable recalling it, we're not going to ask you to fabricate information. At that point, we probably would switch back to the 9921 through 99285 levels of care supported by the HPI, the examining the medical decision making. But we're trying to get ahead of that, and I want you to see more of me coming down with some of these charts and problems so we can work through it sooner rather than later, because I know you're seeing a lot of patients in between to be able to recall that information. I'm hoping it's not with the EMR, it's probably not as many charts as it was in the paper world, because you guys do have that little checkbox that's in there.
So my question for you, Karen, sorry, is that when we go through that critical care section of our EMR there, is that enough? Or are you actually looking back at the chart to see if we build critical care time on something that was inappropriate for critical care? Does that make sense? So just the fact that we actually fill that box out, I'm not saying anybody would ever do this,
Oh,
but
no, we actually, yes, we look at the documentation. For example, I had audited charts a couple years ago, and you read through the documentation, the patient was sitting up in bed eating breakfast, but we had a critical care time. To me, it really does not support critical care.
okay, so that's a,
So we do compare descriptors of what's going on during that time with the level that you've selected on the bottom, if that makes sense.
So is it gonna be better really just to try to estimate the number of minutes instead of?
For me, a good faith estimate, I'll take it.
One of the places you can look is the code sheet, because the nurses
Yeah.
are keeping that code
Yeah.
sheet, so if it's unclear,
sounds like it's more than a code sheet, right? That's what I'm choosing, yeah.
Right, but you could at least look and see, okay, well, we know what time we started, we know what time we stopped CPR, and then that would be a little bit better.
I know you're not gonna have an exact start and stop, but I'll take a good faith estimate in the chart. I spent 43 minutes providing critical care, for example.
My understanding too, correctly too, that the critical care time is billed separately than the procedural time that's done during that critical care. So if I'm putting an access in, is this what you're asking there? If I'm putting a central line in during a code situation, these are two separate billed events?
For you, for the professional component, the access line is going to be included, but we can pick it up on the facility side,
So not on the,
not on your professional. CPR, we can pick up on both. But if it's listed in that one list I had previously, that's included in your professional component, but we can pick it up on the facility side. And I have homework, and I'll get in touch with you, and we'll keep working through it to make sure we get it correct. That's all I have.
does anybody have any questions for Karen?
Just, you mentioned about the teaching of the residents, but also, I don't think you can, the PAs also can't do that, as far as critical care, is that correct? That it's gotta be the physician.
The PA can bill critical care, but they're only gonna get reimbursed 85%. And then also, if an attending is gonna take the critical care code, we can't also bill for the mid-level. It's only one per day per patient. So it's gonna, I would rather have the attending take the code for 100% reimbursement rather than the mid-level. But if it happens that the mid-level's in there and they're the only one there, for example, we will take critical care for the mid-level.
And also there's been in the past, some confusion and sometimes with providers that you can do critical care for patients who aren't what we would think critical, like, people being intubated or you're putting up, pressors. It also, and correct me if I'm wrong, it also encompasses those patients that have a potential of deterioration. So, is that correct?
Yes, if it's, depending on what's going on at the time.
So for example, your atrial fibrillation patient who comes in with a rate of, let's say, 180, that person has a potential of deterioration. Can you bill critical care time for someone like that? Even though, let's say, the blood pressure arriving is, let's say, 120?
I think I'd have to look at the whole entire visit as a whole, because remember, it also is 30 minutes or more, and depending on what you're doing for that patient at that time, it would have to move into, I have to.
Or let's say
see
a
that
patient that you put on BiPAP, because that's a person who could deteriorate and go into, and need to be intubated.
Can you go back to your definition, because I think there's a sentence there that we should look at.
There's one that's critical ill or potential life-threatening.
Close it down, so.
And or to prevent further life-threatening deterioration of patient conditions.
What page you on?
Yeah.
So I mean, that's very much a medical judgment, but what you're saying is this patient is, could go south very quickly and you need constant attendance and et cetera, et cetera.
Right, because that's the group of patients that a lot of people miss on the critical care aspect of things. The slam dunk when someone's intubated, that's easy, okay? But there's that group that
A
a
lot
lot
of
of times we
dynamic,
miss.
unstable,
That's right.
and very worried about them.
Exactly. Anyone that you have BiPAP on, you should be thinking this is part of critical, this is critical care time. Anyone going to the unit, critical care time.
What about the renal patient who's missed his last 3 dialysis attempts and has to move 7.5?
So you could have a heart arrhythmia and go out really quickly with that situation. Is that your concern? So I mean, part of it is it's medical judgment when the physician has to call it that, and it's much better, easier for us to support it when you guys perceive it that way, document it that way contemporaneously. If, because we can't get into all those scenarios that you just talked about and speak with clarity like you did.
So that's what I was gonna ask, is in those situations, because I think those are sort of our top 4 or 5 outside of an arrest situation, is hypoxia, COPD, going on BiPAP. The second would be something like an arrhythmia, rapid AFib. Obviously, if they're hypotensive, I would think that counts, but even if they're normotensive, if you're giving a series of medications, putting them on drips, what was the other one? Yeah, hyperkalemia, where we're giving a whole care set of medications, arranging dialysis. takes for us to at least code for 30 minutes or document 30 minutes of critical care time. And then if you feel, gee, that your documentation really doesn't support that,
I'm
Does
not
that make
clinical, but if you're going through all the motions and that's in the chart and you're telling me it's critical care, I'm gonna take that as critical care. If you're calling it critical care, we're gonna take it as critical care. And again, if it meets the 30-minute mark, we
and
can.
then if you found something like you said, like while they were sitting up eating breakfast, that you could say, gee, it doesn't really rise to that
Correct.
standard, or send it back to us saying, you need to document, you need additional documentation to support critical care time, or it just isn't.
I think my biggest concern is we don't want to be caught in the law.
Mine too.
We don't want to be over-coding.
Correct.
So
I agree.
we need to be very careful, and that's why I think some of these are really tough questions about what we don't want to miss critical care, we do a lot of it. But we don't want to over-code either, and that's my big concern. How do you know, I want to be sure that you can pull us back, if we think it's critical care, you say, no, that's important, but that it truly does not get coded that way, so we don't get audited.
But say somebody's hypotensive, hypoxic, again, elderly septic patient may come in hypotensive, will necessitate giving antibiotics. Are those generally supported for critical care if that's the case, if they come?
Sepsis, yes.
And if they're acidotic and all those other things are going on, that, again, back to your constant attendance and you're pretty much on that case, all of those are pretty good signs that they are. And really, the auditor's gonna come in after the fact, and it's really about how bulletproof your documentation is. If you're really saying that no one really can come back and say it wasn't, we're gonna look at it with the auditor's eye to say, well, were they sitting off, were the clinical indications really that bad? And, we might try to question it just to keep it all, make sure we're not taking critical care lightly. And I think there's probably many times, I know sometimes you have, GI bleeds and the patient has lost a lot of blood, and that's very life-threatening. We go back to that definition, there's a high chance, high likelihood of deterioration. I think there's probably quite a few situations if they're well documented.
And in that case, say Alicia's caring for a patient who's septic, and then I'm the supervisory physician. If I then in the teaching supervisory note put a critical care note that this patient is hypoxic, and gave antibiotics, and again, nebulizers, et cetera, then that was coded at the billed at 100% level. If it's in my supervisory note, I put that critical care note in there.
It will be your supervisory note, but again, it has to be your face-to-face time with that patient, not the bid level, because if the
Not
bid level is
Alicia's.
providing the critical care, we're gonna get the critical care. But if you're coming in to do the supervisory note, if it's critical care, if it wasn't critical care, you're getting credit. If it is critical care, it's gonna be the face-to-face time, because it has to be your face-to-face, not a combination of the two.
What if all the orders are in the PA's name, if we're ordering all the stuff, we're doing all the documentation? Like if we're,
Does it
She's
matter if
gonna
she's
bill
doing
for
most of
it.
the documentation?
I'm doing all the
so-
documentation, I put in all the orders, I'm going back and you see me doing all of that.
Because
part.
she can take your documentation and put it into her note to get credit for it. Even though you did the work up front, she's coming in and taking her own exam and medical decision-making, whether she agrees or disagrees. That's all that's required for documentation in order for the attending to take full credit.
Right, so
It's a combination of the two.
orders.
Correct.
Dr. Rowan, do you have a question?
I was going to ask about conscious sedation.
That's a whole other topic. but I can-
It's
We,
coming next.
that is coming. We're having trouble finding times, like a start and a stop time, because moderate sedation, which I'll talk to next time, is the actual face-to-face time you spend with that patient from the push of the first drug to the time you leave the room, and not at the actual procedure time. So we may be missing some opportunities with moderate sedation, but again, having to work with the EMR and trying to get a spot to put in a specific start and end time for face-to-face in order to get
But
moderate
is it
sedation.
critical care or not?
It's not included in critical care, but if we get past the 16-minute mark, there's a 16-minute mark that we have to pass in order to bill for the first 30 minutes of the code itself. But we'll touch on that in another topic. But if we can pick it up, we are picking it up.
The other two things that we often see that I have a question about are the ones that are so time intensive and rapid, like seaports and stroke guards.
less than 30 minutes, it's gonna revert back to the E&M codes itself. But if you reach that 30-minute mark and you're telling us it's critical care, we're gonna pick up the critical care.
And Priscilla, to say, in those cases, the time you're spending documenting also counts and counseling families, for
Yes.
example. So, because that's what I think all of us do, particularly for Seaport, is you're not documenting until that patient's in the cath lab. And then you have to sit down and document everything you did, time you spoke with Jerry on the phone, or those sorts of things. So
So it just doesn't end with the patient.
it doesn't always end when they leave the department, if you haven't done any of your documenting. So just bear that in mind, and again, as long as you can document to support that, you know, they arrived at 9 o'clock, they went to the cath lab at 9:20, and then, you know, you did an additional 15 minutes to document